So let us discuss about plazomycin. Plazomycin, which was also called as ACHN490, which is a novel aminoglycoside that has been developed to target the multi-drug resistant organisms. It is a semi-synthetic aminoglycoside antibiotic which is derived from cisomycin, modified form of gentamicin. So plazomycin, like any other aminoglycoside, it targets the 30S ribosomal unit and blocks the protein synthesis, and it is bactericidal. So modifications in plazomycin can result in a slightly reduced potency compared to gentamicin, but it makes it effective even in the presence of this antibiotic modifying enzymes, restoring its utility against resistant bacteria. So modifications for resistant are, it includes two specific modification. Number one, N1,2S hydroxyl amino butyryl group and an hydroxyethyl group at 6 position. These changes prevent the most aminoglycoside modifying enzymes from inactivating it, increasing the plazomycin's effectiveness against bacteria that produce these enzymes. But plazomycin could be less effective against bacteria with 16S ribosomal methyl transferase, a resistance mechanism that reduces binding to the ribosome. Efflux pumps and environmental factors can also reduce its effectiveness. So coming on to spectrum of activity. It has the strongest activity against most of the Enterobacteriaceae like ESBL producing, non-ESBL producing, E. coli, Klebsiella, carbapenemase producing Klebsiella pneumoniae, and even polymyxin resistant strains with MCR1 positive negative isolates can also be treated with plazomycin. But it is less effective against Proteus mirabilis, Morganella morgagni, and Providentia species. And other gram-negative limitations could be it has a weaker activity against Pseudomonas aeruginosa and Acinetobacter baumannii compared to Enterobacteriaceae. Coming on to gram-positive activity, it is effective against Staphylococcus aureus including MRSA and Staphylococcus epidermidis, but it has poor activity against Streptococci and Enterococci. Synergy in combination, synergistic with piptas, ceftazidime, carbapenems, especially against the MDR Enterobacteriaceae. Therapeutic uses, it is usually used in MDR gram-negative resistance, especially with the Enterobacteriaceae group. Coming on to pharmacodynamics and kinetics. So the normal dose of plazomycin is around 15 mg per kg IV infusion over 30 minutes once daily. So for dosing, total body weight is used if total body weight is less than 125% of the ideal body weight. But if the total body weight exceeds 125% of the ideal body weight, adjusted body weight has to be used as per the given formula. So normally 10 ml vials with a concentration of 50 mg per ml is the availability. It is diluted to a 50 ml volume in a 0.9% sodium chloride or a lactated ringer solution. So absorption, it has a poor absorption and requires only parenteral administration. The volume of distribution is approximately 25% of the body weight, similar to the extracellular fluid volume. And the C max, that is the concentration max, because it follows the concentration dependent kinetics like any other aminoglycoside. The peak plasma concentration of approximately 51 mg per liter following a 15 mg per kg IV dose in patients with complicated UTI. Protein binding, it is approximately 20% bound to the plasma protein. Metabolism, it is not metabolized to any appreciable extent. Minimal involvement with the cytochrome P450 enzyme, and excretion is mainly through kidney, and 90% of the unchanged drug is recovered in urine within 1 week. So renal modification is always needed in case of plazomycin. As I told you, the dosage adjustment recommended for patients with reduced renal function is 10 mg per kg once daily when the creatinine clearance is 30 to 60 ml per minute, 10 mg per kg every 48 hourly if the creatinine clearance is less than 30 ml per minute. And the half-life is around 3.5 hours in a patient with a normal renal function. So as I told you, it is effective against all MDR Enterobacteriaceae, including the strains producing ESBL and carbapenemases. Synergy, it has synergy with beta-lactams and carbapenemases. Drug interactions, there is no significant interaction with metformin despite shared renal clearance pathways. Coming on to adverse events, the common adverse events are diarrhea, hypertension, headache, nausea, vomiting, hypotension. Cochlear and vestibular events, because it is an aminoglycoside group, it is rare. Serum creatinine increase, rise in serum creatinine more than or equal to 0.5 mg per deciliter noted, and renal function often recovers post treatment, but monitoring is advised. Nephrotoxicity, as I told you, risk increases with higher plasma trough levels, particularly at or above 3 microgram per ml. Monitoring the trough level is recommended. Infections, a rare occurrence of C. diff infections. Mortality, very low mortality rate, not directly associated with the plazomycin treatment. Autotoxicity, potential autotoxicity associated with aminoglycosides. However, plazomycin shows low autotoxicity. Neuromuscular blockade, no reported cases in studies, but caution is advised. Coming on to evidence for plazomycin, I have put in the significant trials. There was a phase 2 trial which compared levofloxacin and plazomycin for acute pyelonephritis, where the outcome was to look for microbiological eradication and recurrence rate, where plazomycin showed a lower recurrence rate and effective microbiological eradication compared to levofloxacin. There was one more trial called EPIC trial, which is a phase 3 trial where they compared meropenem versus plazomycin for UTI, where they looked for composite cure rate on day 5, where plazomycin was non-inferior to meropenem with higher cure rates. CARE trial for carbapenemase resistant enterobacteria infections, where they compared plazomycin with colistin plus meropenem, where 28-day mortality was looked for, where plazomycin showed a mortality benefit over colistin with better tolerability profile but lacked sufficient power by formal hypothesis testing. So this slide shows us the gist of plazomycin spectrum, where it covers ESBL, AMC, KPC, OXA48 Enterobacteriaceae group, but very limited activity for Pseudomonas and Acinetobacter species. Thank you.